So my presentation today is not to do much with IVF, more to do with standard ovulation induction that we do for a routine practice. Excuse me. How do you do? Yeah, it's a standard disclaimer. We will talk about slides which are very commonly seen, and we'll just cover them. There's nothing new that I'm talking. If there is any question, any comment that you'd like to pass, we're most happy to take them. Excuse me, I don't know how to use this. Okay. Okay, thank you. Okay, thank you. And of course, I don't need to teach you guys anything new. So this is the definition of PCO. We all are aware of this. This is what now it's boiled down to, a reproductive and a metabolic disorder. And this is what we are concerned with today, the infertility part. Pathology, basically what matters is the theca cell proliferation, leading to a lot of changes in the body. One thing that I'd like to mention about diagnosis, because we have new and the current things going on, is that now we are using much better machines. Now with these machines, what's happening is that older ultrasound techniques have gone, newer machines pick up much more follicles, and therefore, unfortunately, PCO has now become a very common diagnosis. Not always correct, because PCO is now an overdiagnosed entity. In fact, there's new data that's come out which says that this kind of information would work better. Instead of 12 follicles per ovary, we could look at a number of 19 follicles per ovary with the new ultrasound machine. We could also look at the AMH values really as absolute values to define PCO, rather than what we used to look at in the 2003 criteria. So one good message about PCO is it's rarely infertile. In fact, PCO is a disease with survival benefits or survival advantages. It's one of the oldest diseases that has existed, and most people with PCO go on to give birth in spite of us. The problem with PCO and infertility is it leads to no formation of eggs, the oocyte quality is not good, high rates of miscarriages, but luckily, as I said, rarely completely infertile. You have higher obstetric morbidity also, leading to subfertility. This is the algorithm of treatment. We are all aware of this. We look at the lifestyle modification, then we look at adding metformin and clomiphene, other oral ovulogents, laparoscopic ovarian drilling, FSH, gonadotropin injections, and then ART. Weight loss actually helps. The data that we have says almost 5% weight loss. So you start off with whatever that you have. 5% of initial weight loss has showed benefit. We should be aware, of course, that obesity is not a diagnostic criterion for PCO. And only about 20% women have PCO, with PCO are not obese. And we have to remember this. Weight loss would also help only in women with higher BMI. This is one paper that's there, which looked at 33 women who were not ovulating. And they were all having high BMI of more than 25. They were all given a 1200 kilocal diet for 6 months and 1 year. End of that, most of them lost weight. BMI was reduced either by 5% or by 10%. End of 6 months, 18 out of 33, and at end of 1 year, 27 out of 33 had spontaneous ovulation. So most probably the best tool for obese PCO is weight loss. About diet, yes, it makes sense, but there's no consensus about what diet will work. We talk about low GI diet, and we talk of high GI glycemic index diets, and etc. But when we look at what diet exactly to offer to our patients, there's no one diet which is better than the other diet. What we know, yes, is that we have to give a catabolic diet, in the sense that the diet has to be lower in calorie count. But if you give a low carbohydrate diet, that doesn't necessarily mean that's going to be better in terms of better results. Newer thing that's come out, bariatric surgery. Logically, it makes sense, would definitely cause reduction in BMI. But then you have to look at a lot of nutritional deficiencies that come in, like protein, iron, vitamin B12, folate, vitamin D, and calcium. And we need to be aware of that when we try for these women to get pregnant. Coming to my topic, that is ovarian stimulation. We'll define ovarian stimulation in 3 parts. Ovulation induction, which is the bread and butter practice that we all do. This is women who are not ovulating, and we want them to grow 1 follicle naturally every month. Superovulation, where they are possibly ovulating or not ovulating, but we are looking for some procedure like IUI or something like that. So you want them to grow 2-3 follicles. And controlled ovarian stimulation, which is more the domain of the fertility specialist, where we look for 7 to 10 or 7 to 14 follicles for an IVF. How do you control the ovarian stimulation? You control with the help of a GnRH agonist or an antagonist. What are the common oral medicines that we use? Clomiphene or tamoxifen, metformin, and letrozole. What is clomiphene? Commonest medicine that we've all been using for last, 50 years now. It has both estrogenic and antiestrogenic action. It works as an agonist, as an antagonist. Its efficacy in ovulation induction is because of its central effect. It binds to the hypothalamic estrogenic receptors. It increases, unfortunately, both FSH and LH, not only just the FSH. And it's considered the best initial therapy because we are so used to the molecule. Now, the point is, this is the standard clomiphene therapy. You wait for spontaneous menses, or you give medroxyprogesterone, cause her to menstruate, and you start her on clomiphene 50 mg or 100 mg as soon as the cycle starts, maybe on the second day or the third day of the cycle. You give it for 5 days. Most papers would suggest that she would not ovulate for the next 5 days. So if you're given for 5 days, the next 5 days they need not be together, and then for the next 5 days they're together, the partners, and then you could add progesterone as luteal support, what we were discussing. The good part is clomiphene works very fine as an ovulation induction agent, causes around 70% ovulation, but it doesn't have a very good high pregnancy rate. It's only about 7% pregnancy rates per cycle, or about 9% pregnancy rates where the ovulation has actually happened. So in spite of ovulation, only about 10% cycles get converted into pregnancy, and that's a worrisome area. Why is that happening? We will go into that. So to summarize about clomiphene, however, it's simplest treatment. All of us have been practicing for quite some time. All that we need to do is the first cycle that we do with clomiphene. We need to follow up with an ultrasound or a basal body temperature measurement or a blood test for progesterone to be sure that she's actually ovulated with clomiphene, and then move on to the next cycles. The only risk that she carries is maybe multifetal pregnancy. So the drawbacks of clomiphene, the results are not so good. That's because basically the endometrium thickness doesn't build up, the cervical mucus is hostile, the blood supply to the womb is not so good, and that's because of the two isomers that it contains. It contains two isomers, the zooclomiphene and the N-clomiphene. It seems that zooclomiphene is the bad element. It does not help us because it causes anti-estrogenic actions in the cervical area and the endometrium, whereas the N-clomiphene actually is the ovulation induction agent. It causes anti-estrogenic action and causes release of FSH and LH. Another good advantage about N-clomiphene is it disappears rapidly from circulation in less than 24 hours, which is what you would expect of your ovulating agent, because you should not remain in the system for long. And on the other hand, zooclomiphene is in the system for a long time, more than a month. So therefore, N-clomiphene makes more sense to be used. And if there was a technique to separate N-clomiphene from zooclomiphene, that would be a better molecule. Unfortunately, there are pharma companies who are promoting N-clomiphene only products, but the data doesn't really hold up. We haven't been able to prove for sure whether they actually contain only N-clomiphene and whether the separation has happened properly or not. So logically, yes, the newer molecule would be an N-clomiphene, which will do maximum work for clomiphene without the side effects. As of now, clomiphene doesn't have anything new to add. There's something new that I picked up in the IFFS conference last month, and that is the luteal phase addition of clomiphene. So what they're doing in this is that to take away the bad effect on the endometrium and the cervical mucus, they're adding clomiphene from the first day of stopping medroxyprogesterone for 5 days. And what that helps is possibly increases in the levels of estradiol, more follicles, and a higher endometrial thickness. Whether that translates into a pregnancy or not, or a higher pregnancy rate, we do not know. So this is the data or the evidence behind it. They talk about higher E2 levels, more follicles, better endometrium, but pregnancy rates, because it depends on a lot of other variables, still not defined. So you, of course, have a situation of CC resistant, where she is not producing follicles, or a CC failure, where she is producing follicles but not getting pregnant. In either of these situations, you move on to something new. So we had a tool, letrozole, aromatase inhibitor, but unfortunately we're not allowed to use it. The usual standard dose was 2.5 milligram once daily from day 3 to day 7. And this is one paper from Richard Legro, who is a big believer in letrozole. which says that it works better in all scenarios. It works better than Clomiphene for all patients, in women with higher BMI, in women with lower BMI, in PCO. So there is good data, this is good data, which says that letrozole works better than Clomiphene, but unfortunately, it's not universally accepted, long-term safety profile not known, and most importantly in our country, it is not approved to be used for ovulation induction. There are two other similar molecules, all of you are aware, tamoxifen and anastrozole. Anastrozole and letrozole head-to-head, letrozole is better. And if the reasons for letrozole not to be used are so strong, I don't see any reason why anastrozole should also be used by us, so far as the clarity is not there for ovulation induction. And tamoxifen again gives better endometrial thickness than Clomiphene, but usage and advantages in PCO is not very well defined. Adjuncts, in India we have a bias towards using adjuncts in huge quantities. The adjuncts that we basically can use or are using in huge quantities are metformin. Myoinositol is the new kid on the block, but their role is very limited, possibly only in obese, hyperinsulinemic women with documented impaired glucose tolerance, intolerance, etc. If you compare Clomiphene with metformin, this is again a very good paper which was there in 2008, I think, which compared Clomiphene, metformin, and a combination. So it clearly shows that combination is better than Clomiphene, and Clomiphene is better than metformin alone. So metformin alone is not a very good agent as far as ovulation induction is concerned. However, it may improve egg quality, may decrease the risk of ovarian hyperstimulation, etc. But as such, as an ovulation induction agent, it doesn't stand any chance compared to Clomiphene. If they have done head-to-head Clomiphene versus metformin, and the pyramid or the diamond is in favor of Clomiphene. This is another way of looking at the combined therapy group, the Clomiphene group and the metformin group, and all of these, whether they are hirsute, whether they are obese, in all of these it seems that the combined group works best, then Clomiphene group, and then metformin as far as ovulation induction leading to pregnancy is concerned. What is the use of all these adjuncts? They basically help in increasing the concentration of PI3 kinase, which helps in glucose utilization. So you have a lot of molecules such as myoinositol, vitamin D, and chromium, which can be used for this central diagram where they increase the utilization of glucose intracellularly and therefore help in impaired glucose tolerance. But they have very limited effect as far as ovulation induction is concerned. Maybe they help in other aspects of PCO, metabolic aspects of PCO, but not really in ovulation induction. Experimental molecules are also there, like resveratrol, like statins, etc. But we will not spend time on that because we're not very sure whether it works or not. Back to the algorithm, therefore. So you give Clomiphene, maybe 50, doesn't work, you move to 100. More than 150 doesn't work. If there's still no result, then you add metformin to it. The standard dose would be 1550 to 200, 2500. And along with that, if you are ovulating, you try for 4 to 6 cycles. If it doesn't work out in 4 to 6 cycles, then you have to move to the other aspects, whether it's ovarian drilling or gonadotropins or IVF. Ovarian drilling, I'm not much of a laparoscopy person, but this is a standard ovarian drilling protocol. You put in 4 or 5 holes each ovary, and you go as little as possible and use as little current as possible. Gonadotropin therapy is the most logical therapy you would use for PCO induction. It makes the most sense because the lady requires FSH from outside for helping us in selection of follicles. So you give either FSH or you give a FSH-LH combination in terms of HMG, and you use HCG.
Dr. We are at the last 1 minute.
3 minutes. Okay. So these are the 3 protocols: step up, low dose, and step down. The standard dose is 50 IU or 75 IU. You go as low as possible. You do your ultrasounds every 5th day, and when the follicle reaches 15, 16 millimeter in size, you stop and you give an HCG trigger. This is the standard typical FSH HMG IUI protocol. Whether to give FSH or HMG doesn't make any difference. Whether to give from day 2, day 3 makes no difference. As logic would say, these people require FSH, so pure FSH or recombinant FSH can be used in higher quantities with these women. But again, there are so many PCO women, almost 10% of women in India are documented to be having LH receptor polymorphism. So these women actually have endogenous high levels of LH, And in spite of that, because the inactivity of the LH, they require LH-containing molecules from outside. So for these women, you need to add HMG rather than FSH. In IVF, the only thing you have to be careful about is OHSS and oocyte quality. There you can use metformin, and you can use tools as expressed by Dr. Madhuri, how to prevent and stop OHSS, but that's for some other discussion. Thank you.